Hello everyone, welcome to the latest edition of the Olea Medical Education Webinar Series. My name is Stefano Casagranda. I'm a Research Innovation Team Leader and Molecular Imaging Project Manager at Olea Medical. Today we will indeed talk about molecular imaging and in particular about chemical exchange saturation transfer and amide proton transfer weighted imaging. So we will have two presentations from experts of this field, and I would like to welcome to Dr. Daniel Paech and Dr. Lucia Nichelli. Dr. Paech will talk about CEST imaging in neuro-oncology and its diagnostic potential for tumor subtyping and therapy response monitoring, while Dr. Nichelli will focus on the added value of amide proton transfer weighted imaging in post-treatment brain tumor evaluation. So I want to thank both speakers and everyone of you to be here with us today. And before I move forward, we can review the functionality of the Zoom system. So all your microphone will be mute, but you are encouraged to participate via chat, asking your question to the speaker. And I will submit your question to Daniel Paech and Lucia Nichelli at the end of their presentation in the roundtable or Q&A session. So we can move to the first presentation. I'm very pleased to introduce you to Dr. Paech. And Daniel Paech is a board-certified radiologist and currently works as a senior physician at the Clinic for Neuroradiology, University Hospital Bonn. He's also leading a research group in 7 Tesla MRI at the Division of Radiology, German Cancer Research Center, Heidelberg. He's a young radiologist, board member of the European Society of Oncology Imaging, and of the German National Academic Merit Foundation as member of the selection committee for high school graduates and advanced students. He's the recipient of the 2020 Walter Frederick Prize for research on metabolic imaging techniques using 7 Tesla MRI for neurological diseases, and he has published more than 7 peer-reviewed papers in CEST and neuroimaging. So thank you very much, Daniel. You can start the presentation.
Yeah, thank you very much, Stefano, for the very kind introduction and for having me in the Olea Medical webinar. I will talk about CEST imaging in neuro-oncology, and I will specifically focus on the two, in my opinion, one of the most interesting aspects where this new method could really aid clinical decision-making. First of all, I have nothing to declare related to this talk. Can you see my slides advancing? Yes, right?
Yes.
Perfect. So as I said in the beginning, I will focus on these two, in my opinion, very interesting aspects, which is the tumor subtyping with CEST related to different histologic subtypes of these tumors, specifically in gliomas. In the second part, which is labeled as 3 here, I will focus on therapy response monitoring, both in the follow-up setting and also at initial diagnosis. So we will try to have a look at the CEST data, if it's possible to do some prognostication on therapy outcome survival and progression-free survival. So let me introduce my talk with a general outlook, what I expect medical diagnostics to be like. So, of course, probably looking for the one contrast that will answer all questions in oncology is not very realistic. We will rather face a scenario like this, where we have a lot of data coming from different clinical fields, epigenomics, metabolomics, etc., also radiomics or AI approaches. And I see that CEST imaging could make an important contribution here because it probably adds independent data to the process of MR diagnostics. So I always like to show this slide from IBM because it shows where we actually stand as medical imagers. So they locate us here at the level of the organs with diffusion-weighted imaging. We are at least at the cellular density level. This is well known. But with CEST imaging, we get the chance to go way beyond that. We get the chance to go on the protein level. And in my opinion, this really bears the potential to add independent information to this diagnostic chain that I showed in the initial slides. So for those of you familiar with CEST, this is very superficial. For those not so familiar with CEST, I always like to introduce the method as a comparison to MRS, because we all know spectroscopy. In spectroscopy, we also try to target metabolites, but we have the disadvantage that these are very low concentrated. Of course, also in CEST imaging, the metabolites are very low concentrated, but I'm measuring these metabolites via chemical exchange with a water pool. So I'm combining the advantages of general MRI and the specificity of magnetic resonance spectroscopy. Of course, we don't get a spectrum in CEST imaging like we are used to get in MRS, but still we get a metabolite-related contrast. So pilot studies investigating brain tumors in the clinic showed that we generally observed increased protein signal in these tumors. I say protein signal generally, this is related to the amide proton pool, which is located in the backbone of proteins. And these studies initially here performed by Jones et al. And Wen et al. Showed that in the viable tumor cores, this signal is specifically elevated compared to contralateral normal appearing white matter, also nicely demonstrated here in this high-grade brain tumor. So high-grade brain tumor, I said, we have different histologic types. When we approach different histologic types in brain tumors, very basically, we can divide these into two groups of higher and lower grade gliomas. Higher grade gliomas are usually grade 3 and 4, lower grade gliomas grade 1 and 2. This is what we used to classify brain tumors in the recent decades, let's say until the middle of the last decade. And this was also investigated with CEST. I'm just showing this important work here from Tugao et al. In 2015, where he nicely demonstrated, you can see here in the scatter plot, that the signal is elevated. Also, again, the APT signal is elevated in high-grade brain tumors compared to low-grade brain tumors, and that this also correlates with the Ki-67 labeling index. This is a labeling index from histology that is related to cell proliferation and cell density. Also here, manual cell counts done by histologists correlates with the APT signal. And there were several confirmatory studies so far published in the literature, so that we can say quite sure right now that the APT signal is correlated with the tumor grade. Interestingly, from a radiologist's perspective, this also holds true for diffuse gliomas without intense contrast enhancement. So this is something I can tell you as a neuroradiologist. When I see a tumor like this, which only shows very moderate or almost no contrast enhancement, we used to say probably this is a lower grade tumor, but in about 10% of cases, we are wrong. And what we can see here in these AUC curves, that also here APT imaging could significantly improve the prediction of the tumor grade. So CEST imaging seems to be independent of this contrast enhancement associated with the tumor grade. Very interesting. And also vice versa, as Stefano would say, we see this for tumors that mimic high-grade brain tumors, but are actually low-grade brain tumors. So there are some low-grade brain tumors out there that show pronounced contrast enhancement, but still are low grades from the histology report. And also here we see both in the upper row for the APT MTR symmetry elevated signals in the higher grade tumors. And also this is compared to CBV. CBV means cerebral blood volume perfusion imaging. This is also a contrast that we usually or regularly use in neuro-oncology. So both these methods are very helpful to differentiate higher from low-grade brain tumors. So I've also already said in the beginning that high-grade versus low-grade brain tumor is a very basic distinction. This is today not what we are looking for. But what are we looking for at clinicians? So this is from 2016. There's already a 2021 version of the WHO classification of brain tumors. And then we see that our field moves to an integrated diagnosis with several histologic information. So the histologic information that is very, very important for the grading of tumors is the IDH mutation status. You see that it's relevant for all the different stages. And then also depending on the type of the tumor, ATRX and 1p19q correlation are also important for the subclassification of tumors. We get a final integrated diagnosis in the end related to these histologic subtypes. So we are currently looking for biomarkers that help us non-invasively identifying these different subtypes. And there are already quite a few studies right now published in the literature, and we will go through some of them, and I will also show an overview in the end. Let me start with the IDH mutation status, since this biomarker is very relevant for gliomas. Why can we expect seeing something in APT or CEST imaging in IDH mutated versus wild type tumors? This is easy to explain. IDH mutation is good. This means we have lower protein turnover in these patients. We expect lower APT and protein signal in the IDH mutated tumors. If you look into this overview here on the left-hand side, you also identify the 2HG. The ones of you that are familiar with spectroscopy know that you can target 2HG directly as a biomarker of IDH mutation status, and that CEST imaging or APT imaging is an indirect marker of IDH mutation due to the global downregulation of proteins. So this was the first work published by Yang et al. Investigating IDH mutation status in grade 2 and 3 gliomas. And I want to draw your attention to figure D. Here you can see both the different curves for the IDH wild type and the IDH mutant tumors, and you see a clear shift of the wild type version to increased APT values. So this confirms what we expect: higher protein levels, higher protein turnover in the more aggressive IDH wild type tumors. We did a similar investigation at 7 Tesla in a slightly larger cohort involving grade 2 to grade 4 glioma patients, and we also saw a very strong association of the APT contrast. This is a downfield NOE suppressed version at 7 Tesla of the APT signal, and we really saw a striking association with the IDH mutation status. So thinking about the correlation with low and high grade tumors, is this a contradiction? No, it's actually not. We also tried to reproduce this correlation with differentiation of low-grade versus high-grade tumors, and then you can see that you also get a nice correlation or an AUC of 8.3, 0.83. This is also a moderate to good association, but you begin to understand that the association with the IDH mutation status seems to be even stronger than with the tumor grade according to higher versus low grade tumors. And this is also the direction where the WHO classification moved to. So this important factor related to diagnosis and outcome also seems to be reflected in this contrast. Another important histologic subtype in gliomas, especially in glioblastomas, is the MGMT promoter methylation status. And I will not go too much into the medical details why this is the case, but it is important to know that a methylation of the DNA yields a different response to chemotherapy. And you can see here a better survival for the methylated versus the unmethylated patients. So people also tried, or researchers also tried to investigate associations with the MGMT status. And here again, a work from Yang et al. Showed an AUC of 0.8 to 0.86. Again, you see here the shift to higher APT values in the MGMT unmethylated tumors, which seems to be plausible because they have a worse prognosis. We tried to also look into this association and we couldn't find clear significant results here. We only found a trend towards increased signals also in the unmethylated tumors, but no significance here. So we want to look into the literature, what is published on these different issues. So first, IDH mutation status, super clear. So here you see all the studies investigating IDH mutation with CEST, different CEST contrast, found significant outcomes. MGMT, it's not that clear. We have 4 works out there related to this recent review paper. And here we see 2 studies that did not find significant differences in MGMT, methylated versus unmethylated tumors. 2 studies found significant differences. So this is an aspect that's still under debate or under investigation. And I think we will face larger cohort studies in the future where we will better understand if there is an association or not. Second major clinical challenge that I want to discuss right now, and the second field where I think APT imaging or CEST imaging could really aid clinical decision making. This is therapy response monitoring and also prognostication. In therapy response monitoring, we have a very, very difficult phenomenon, which is called pseudoprogression. So here you see at 7 months follow-up, a clear increase in contrast enhancement and also in flare edema. So this would be suspected of tumor progression or pseudoprogression. For this patient, actually, here a biopsy was performed and showed these changes were only related to therapy. So we had a case of pseudoprogression, and you can also see again here a decrease in contrast enhancement and flare edema. But from the standard MRI sequences, I would not be able to tell as radiologist if this is a true progression or pseudoprogression. Daily clinical problem. And we face these problems in different therapy settings. So I want to start with a study from Park et al., who looked into patients under bevacizumab therapy. That's a medication usually given in patients with glioblastoma. And also here we found associations with treatment, and different works from other groups looked into the standard approach, which is chemoradiotherapy and surgery. And here I want to quote 2 different works. One is from Meissner et al. From our laboratory. The other is from Merabian et al. I usually like to show these 2 studies together because they investigated the same question but measured at different time points. Here you can see when Merabian et al. Acquired CEST data at 3 Tesla, and where Meissner et al. Acquired CEST imaging at 7 Tesla. So here, T0, that's where the chemotherapy starts. And then here, 6 weeks, chemotherapy is over, and here, follow-up. So basically, the difference is that Merabian looked into measurement time points under ongoing therapy and Meissner before and immediately after. Both groups found significant associations with tumor response versus tumor non-response to therapy. Here you see, this is one example of NOE imaging, also a contrast that is accessible with CEST imaging, where you can see that from pre-treatment to post-treatment, these lines are divergent for responders versus non-responders. Similar trends here seen for Merabian et al. Interestingly, also from the pre-treatment, just differences. For APT images, Merabian could predict therapy response. I will go into detail of these prediction aspects in the next part. This is actually the last part of my talk. So prognostication prediction means we have the stage of initial diagnosis of the tumor, and we want to predict, is this tumor responding to therapy or not, and does this patient face a good or a worse prognosis. Here is one work from Regneri et al., 40 patients that underwent CEST imaging prior to therapy. Here you see you had 9 cases of stable disease, 3 of pseudoprogression, and 8 of early progression. And again, with both the NOE-weighted approach and the APT-weighted approach, it was possible to differentiate first-line responders from non-responders based on the pre-treatment MRI. So very interesting that this is a prediction of outcome. Is it also possible to predict survival and progression-free survival? There are 2 studies published right now investigating this question. In one work, we looked into associations of the APT contrast at 7 Tesla with patient survival and progression-free survival. And here, both for the APT contrast and again, this downfield NOE suppressed APT version of the contrast, we found associations with relatively increased APT signal and worse outcome. So again, an association that makes sense. So high protein turnover, high protein density associated with worse outcome. Similar investigation performed by Zhu et al. You can see here on the left-hand side the survival time in days, on the right-hand side the progression-free survival time. And here again, for the higher APT signal, which represents the blue line in both cases, we see better outcome. Sorry, for the green line, which represents the higher signal, the worse outcome, and for the lower signal, the better outcome. So these 2 studies perfectly match and show that based on this pre-treatment scan, we see associations with therapy outcome. Again, I do not only want to show 2 studies, I want to try to give you an overview of what has been published. So don't be afraid, you don't need to read every of these lines. I highlight the ones that found significant associations based on therapy response assessment. So this means here we look post-treatment or during ongoing therapy if we are able to differentiate progression from pseudoprogression or early response from early progression. And here we can see for the APT contrast, in 6 cases, significant associations. And in this study from Meissner et al., the one I showed you, they were not able, or we were not able to perform a differentiation based on the APT signal, only on the NOE signal. This is why this study appears twice here in this list. Mirabian is listed in red here because post-treatment, these changes that we have seen during ongoing therapy and at initial diagnosis, these changes somehow disappeared. So it seems like CEST contrasts are most sensitive to assess early response to therapy and not late changes. So this is also confirmed by this overview where you see the studies that investigated the prognostication aspect. And here we see only studies highlighted in green. One is in gray because here we don't have an APT or NOE contrast. Here we have a pH-weighted amine contrast, but also here we have seen significant associations. So let me summarize what I've talked about right now. So I've tried to give you an overview of these 2 aspects, which I, as a neuroradiologist, think to be very promising for a CEST application in the future, because the APT contrast, or in general CEST contrast, provide complementary information to existing approaches in MRI. We have seen, or we have striking evidence that there are associations with genetic subtypes of gliomas and brain tumors in general with the WHO tumor grade, and especially with the IDH mutation status. There are numerous clinical applications where CEST imaging is currently applied. I think specifically in this follow-up or prognostication aspect, it is very promising, because you have to imagine under ongoing therapy or also in the follow-up, we are not able to perform tumor biopsies over and over again. At the initial diagnosis, I think we will still have the tumor biopsy for a long time. But in the follow-up setting, you cannot perform biopsies over and over again in these patients. So the next steps will be a prospective validation of these maybe 50 to 100 patient cohorts that we have seen so far. We will probably see multi-center and large cohort studies with APT-weighted images, with APT-weighted imaging in the near future. And I want to motivate you, if you're planning to do these studies, to look into this recently published review and consensus paper on clinical APT imaging and brain tumors, because here the relevant parameters from many experts in the field have been constant. So please take a look into this paper before starting your study, that you're performing CEST and APT-weighted imaging in the way that the society believes is correct. And there's one last thing that I want to mention. If you're curious to get more familiar with the field, or if you're already very familiar with the field and want to share your ideas, we're very much looking forward to welcome you in the CEST workshop, which will be held this year in August in Atlanta. It's still possible to submit your abstracts there, and I'm happy to discuss with you about my talk after the session. So with this, I'm done with my talk. I want to thank you for your attention, and I want to thank my group in Heidelberg and Bonn for the great collaboration and the great work over the last years that made this all possible. Thank you.
Thank you very much, Daniel. That was a brilliant presentation. And so we can move to the next presentation. So our next speaker is Lucia Nichelli. So Lucia is a young neuroradiologist who works at La Pitié-Salpêtrière University Hospital in Paris, in France. She also is a PhD candidate in neuroscience at Sorbonne University. And in her research, she's exploring non-invasive tools for brain tumor pre- and post-therapeutic assessment, with a focus on the clinical role of edit MRI spectroscopy in glioma diagnosis and on the APT-weighted imaging in the brain pre-radiate metastases. She authored and co-authored over 20 peer-reviewed papers in neuroimaging. And so, Lucia, you're more than welcome to start your presentation.
So thank you, Olea Medical, for giving me the opportunity to present my ongoing research on added value of APT-weighted imaging in the post-treatment evaluation of brain tumor. So I will rapidly review the link between APT-weighted and cellularity, and for the non-doctors, the problem of radiotherapy. And then I will focus my presentation on the interest of APT-weighted imaging in metastases that have been previously irradiated. So APT-weighted imaging, as Professor Paech have illustrated, is a type of chemical exchange saturation transfer imaging for 3 Tesla MRI. And mobile proteins and peptides are the main contributors to its contrast. So it's an indirect measure of the mobile proteins and peptide contrast, because it can measure the amine group of a molecule. And the link between the tumor and APT, it's cellularity and protein, because the protein because the protein concentration in tumor is increased, and therefore there is an increase in APT-weighted signal. So it's an in vivo imaging without contrast administration, and as Professor Paech said, it can lead to a lot of information at baseline. So it can help grading, the identification of genetic markers and prognosis, but is also very useful in post-treatment assessment because, as Professor Paech said, we cannot continue to biopsy the lesion, and therefore it can help in the clinical challenge to in the discrimination between treatment effects and tumor recurrence, and it can help in the early identification of tumor progression or response. So radiotherapy is well known to be a fundamental option in neuro-oncology, but the problem is that it can lead to several radio-induced brain tissue lesions. And among these lesions, the most common one and the most problematic one is radionecrosis, because it is somehow often difficult to distinguish radionecrotic lesion from tumor progression. Is impossible on conventional imaging, as Professor Paech said, and so we use normally brain perfusion imaging, that it's the multimodal technique that can give us the highest diagnostic accuracy, especially if it's integrated with spectroscopy. But there are lots of limitations and pitfalls of this technique, and clearly there are major consequences on patient care. So we have to answer to this important question: is the tumor progressing, or is it a radionecrotic lesion? So here is an example of a clinical scenario. Here was a young patient with breast metastasis that has two lesions, one of the caudate, right caudate lesion, and the other one of the left insular. These two lesions were both treated by radiotherapy, stereotactic radiotherapy with gamma knife. And at the first follow-up, after 3 months, both the two lesions diminished in volume, as we can see on FLAIR and T1 post-contrast image. But at the second follow-up, while the insular lesion continued to diminish, the other on the right caudate nucleus augmented, increased in size on FLAIR image, and the contrast enhancement changed. The pattern of the contrast enhancement changed. So is it progression, or is it a radionecrotic lesion? This is a crucial questions that we have to answer. So our study, as you can imagine, was to the purpose of our study was to evaluate this sequence, APT-weighted imaging, in the prediction of the distinction between radionecrosis and progression. We examine only metastasis, brain metastasis at pre-Tesla on a prospective basis, with the hypothesis that tumor progression will lead to an increased APT signal because of hypercellularity, while radio-induced brain remnant will lead to a decreased APT signal intensity because of low cellular density. And the second aim of the study was also to compare the diagnostic accuracy of APT imaging with the standard references, that is, dynamic susceptibility contrast perfusion. So we examined 20 evolving enhancing lesion, 19 patients. All lesions underwent one single dose of stereotactic radiotherapy with gamma knife, and the final diagnosis was either provided by histological examination or 6 months at least follow-up, or for a few cases, PET-CT confirmation. We all examined the patient at a 3 Tesla SCARA system with APT sequence that had a 2 microtesla B1 value, and with our Zabi sequence that helped to simultaneously calculate B0 and B1. And we also, for all the patients, did IC perfusion with a low flip angle and a single dose of gadolinium. And the post-processing of perfusion and APT sequence was done with Olea software. So the first result was that we did find a difference between the radionecrotic group that had lower values. These values are normalized with contralateral normal appearance white matter in comparison with progressing value. And but we also find, and it was quite interesting, that a fluid suppression lead to a better separation on the two groups, as we can see in the graph. If we compare APT and fluid suppressed APT with RCBV values derived from dynamic susceptibility contrast perfusion, we can see that the accuracy is much higher, especially for fluid suppressed APT weighted sequence. And here are some examples of left occipital lesion, a metastatic lesion that was treated and was evolving. We can see here axillary imaging and T1 weighted post-contrast image, which is superposed with dynamic susceptibility contrast perfusion. So as we can see, there is no clear hyperperfusion inside the lesion, while with APT-weighted fluid suppressed maps, we can see that there's a highly elevated increased emit signal. Interestingly, not only in the lesion, but also in the edema that surround the lesion. And as a neuroradiology, I think I was quite surprised at the beginning, because we are used to know that the vasogenic, that the edema around a metastatic lesion is vasogenic, while the edema around a high-grade glioma is more infiltrated. But there are some evidence in literature that this is not true, that there's tumor infiltration even around in the edema that surrounds a metastatic lesion. And here is what I see with doing a PT-weighted sequence. And this was a progression lesion that was confirmed with histological examination. Another example of a lesion that it's another left occipital lesion that was treated by radiotherapy and that was evolving. It had a lot of hemorrhagic remnants, as we can see on this flare, because the signal on flare is very low. And as we know, as a radiologist, hemorrhagic remnants can lead to false high signal in DSC perfusion, as in this case. While in this case, so the signal was doubtful in DSC perfusion, but with APT-weighted signal, after fluid suppression, we found that there was no increased signal, and we suspected radionecrosis, and the follow-up confirmation confirmed this diagnosis. And this is a nice example of the third result that we are finding during this project, is that APT can somehow make an earlier diagnosis. So this is an example of a lung metastasis that was treated with focal radiotherapy, and we can see here that is a linear, non-nodular, aspecific contrast enhancement that is surrounded by edema that has a lot of hemosiderin remnants, no restriction, no diffusion restriction, and no hypervascularity on RCBB maps. But on the contrary, on fluid suppressed APT-weighted image, we see a nodular formation that is in the distance if we consider the T1 post-contrast image. We follow up this patient, and 3 months after, we saw that the patient developed a lesion that was surgically confirmed and histologically confirmed to be progression. Another example of APT-weighted earlier diagnosis. So this was a case, a difficult case of neuroendocrine metastasis that continued to increase in volume, in size after radiotherapy. And there was no hyperperfusion that was seen. And on fluid suppressed APT weighted, we saw a high signal in the lesion. We continued to follow up the patient, and 9 months after, the signal continued to increase. The signal of the AMIT signal continued to increase, but no hyperperfusion was seen. And 1 year after, only 1 year after, both ASL perfusion and DSC perfusion noticed that there was hypervascular area, and so the diagnosis of tumor progression was made 1 year after with perfusion and in comparison with APT. So I don't want to say that we don't have to do perfusion, that it's not useful. That is not at all the message. The message is that the perfusion and APT are complementary sequence, as we can see in this case, in a glioblastoma case, where hyperperfusion is evident in the anterior part of the lesion, where the signal in APT it's not that increased in comparison with the posterior part, and in this posterior part there are no neoangiogenesis that it's seen. So to conclude, our results are in line with previous works, and they suggest that IPT weighted can indeed distinguish between progressing and radionecrotic lesion, and that for the first time we are showing the evidence of the importance of suppressing fluid signal in APT weighted maps in this post-treatment assessment. And of course, there's limitation, and there are several future directions. A wider population is needed, and aiming range and noise contrast have to be explored. Multicentric study had to be done to validate this technique. And as in the last paper that Professor Paech suggests, we will probably do a protocol with a high duty cycle to increase signal to noise ratio. So what about our first case? Was this progression or radionecrosis? At the second follow-up, so we did perfusion and APT weighted image, and perfusion didn't notice hyperperfusion. There was no hyperperfusion, but in the contrary, there was increase in AMIT signal. And at the third follow-up, after 3 months, the lesion continued to increase, and there was hyperperfusion. So at the end, it was tumor progression. So thank you very much, and especially to my chief, clinical and research chief, Stefano.
Thank you, Lucia, and thank you both for this great speech. And so we have some questions for you in the Q&A chat. And so the first question is for Daniel. So the question is the predictive power of CEST on treatment response independent of the association with molecular markers? Meaning, can you compare the predictive power from CEST imaging to the one of molecular markers such as IDH mutation?
Yeah, that's a very good question, and it also kind of overlaps with the second question from Hyang Heo. So I think we have to do also some expectation management. So what can we actually expect from APT-weighted or CEST imaging? So specificity will remain limited to some extent, of course, because we measure something that is related to proton exchange, probably also with amide density or protein density, but we don't measure a very specific metabolite like 2-HG in spectroscopy, for example. So I think the associations we are seeing with response to therapy, with survival and progression-free survival are of course also related to the fact that tumors that show an IDH wild-type, for example, with high protein turnover, with high cellular density, these tumors have a worse outcome. So this is an indirect association of histologic associations of histologic subtypes and their prognosis in general. So of course we will not, it is just not possible that the contrast will be specific to all the markers we are testing, right? So this is an indirect relation we're seeing.
Perfect.
But still very helpful for clinical decision making, potentially.
Thank you, Daniel. And do you think that you replied also to the question of Hie Jung Giheo, or we can I can read his question?
Sure.
Okay. So very nice talk, Daniel. I have a question about APT signal source. APT MRI can differentiate many different tumor pathology, MGMT methylation, IDH mutation, low grade versus high grade, active tumor versus treatment effect. Are these different cutoff APT signal intensities from different mobile protein concentration levels? Do you think that different saturation parameters need to be optimized for different tumor pathology studies or only for different target CEST molecules? Example, APT.
Yeah, that's what I tried to say already with my first answer, that I don't think we will face different cutoffs for all these markers. I think we see this indirect associations with protein turnover, with cellular density that are associated with some subtypes in these tumors, and this is the reason why we also have this overlap with the prognostication, but different parameters will be relevant when we do different approaches, like the amide-weighted approach, for NOE-weighted imaging, we know, and also for different B0 field strengths. If we go to 7 Tesla, then of course different parameters, lower power in general is recommended. Of course, yeah, for different approaches, different parameter settings, but I don't think that in the end there will be a list of cutoffs that will yield a very specific identification of all these subtypes.
Perfect. Thank you, Daniel. So I have a question for Lucia. So why, in your opinion, fly suppress amide proton transfer weighted imaging is working better than amide proton transfer weighted imaging for the distinction between tumor progression and radionecrosis? What is the added value of the fly suppression?
Because it's a very interesting question, because radionecrotic lesion have got a lot of liquid remnants and a lot of hemosiderin that we can suppressed with fluid suppression technique, and this can diminish the falsely positive image and values. So
yeah, perfect. Thank you, Lucia. And I have another question for you. Clinically was great to see amide proton transfer weighted imaging used in clinical routine. I was also impressed that you use Wasabi acquisition. Do you think that Wasabi visual mapping improved the quality of amide proton transfer weighted imaging? Did you see an added value for to this sequence?
Yes, absolutely. It's needed, and it's extremely important to do it to better quantify the signal, to correct B0 and B1 inhomogeneities, and it has a fundamental value. Yeah.
Thank you.
So, I also have one question to Lucia. Thank you for your talk. It was really really great. I'm wondering, are you using the sequence also in oncologic boards in tumor decision making, or is it pure research so far?
That's a good point, and it's also it's a it's difficult in clinical because IPTs, for example, for the patient where progression was predicted 1 year before, I had this image on APT weighted, but I only have WIP sequence, and so I cannot lead the patient care with WIP sequence or with sequence that have not been validated. So it's a continuous discussion with clinicians because of the fact that these sequences are not validated yet. So that it's there's so I see that I suspect progression, so especially when I suspect progression, but there's no evidence on perfusion. I say to the my surgery colleague, neurosurgery colleagues, and that I suspect progression, but it's difficult to have a clinical decision, to make a clinical decision. I don't know what's your
right. Yeah, right now I can also work with a sequence that is FDA and CE approved. So this is regularly, not always, but regularly asked for neuro-oncologic boards. But regarding the robustness compared to, or also the experience, let's say, compared to perfusion, it still doesn't play the same role in our boards. It can be an additional factor, let's say. So they ask, what does CBV look like? Do you see something in the APT image? But it's never the primary approach so far. Yeah. But it's interesting that we are moving towards oncologic boards anyways, with the sequence.
Yeah.
Thank you both of you. I have another question for Daniel. So is there any cellular or physiological basis for investigating the association between APT changes and MGMT methylation status?
Yeah, super good question. I have been wondering, or I've been asking myself the same question. And actually, I have to say that I do not know a clear association that is that would explain significantly or a clearly increased APT signal in MGMT methylated versus unmethylated tumors, because it's just a different methylation of the DNA, and which becomes important for repair mechanisms, which is the reason why chemotherapy works better or worse in the two different states, but it's not relevant for cell proliferation or protein expression, etc. So there's not such a direct link as we see, for example, in the IDH status or in the tumor grade. So for me, MGMT remains still very unclear, and from the histologic point, I do not see a very clear rationale why there should be a strong association.
I see. And thank you, Daniel. And so I have a question for you. So regarding True Tesla MRI scanner, so for who is approaching to, let's say, not only APT weighted, but also to, let's say, NOI biomarker and so on, do you think is a better idea to have a protocol where AMID and the NOI biomarker can be extracted by Lorentzian fitting, so to have them as a distinct biomarker, or do you think is easier to, from the clinical point of view, to have, let's say, a protocol that is emit proton transfer weighted, and a second one that is NOE weighted, and perform the asymmetry to extract the two biomarkers that are not exactly emid and NOE, but which the main contribution is from emid and the NOE? What is your experience between the extraction of the pure signal or the weighted signal?
It depends very much on your setting. If you're in a standard clinical setting, let's say a university hospital somewhere, where you have high patient throughput over the entire day, and you want to use the sequence in a clinical routine, then I would recommend to use the APT-weighted approach, which is FDA cleared with the set of parameters, which is well known, where we have a lot of literature telling us these associations that we have talked about right now. So this would be my recommendation for the clinical setting, with maybe also a research focus on the broad clinical large-scale application. If we want to go into more detail, more basic research, the NOE contrast is not that well explored so far as the APT contrast is. And if you have a spectrum or an approach that allows you to nicely separate the different pools, then of course it's interesting to have this independent information. And also, if we think about these future directions where it said maybe different contrasts will add independent informations, or using the entire Z spectrum, put this into a machine learning approach, not even the contrast in the end. This could be even more helpful. So if you have time, if you're in a research setting, then cool, acquire a highly resolved Z spectrum. If you're more clinically focused, go with the APT-weighted approach.
Thank you, Daniel. And also, you were showing some slide extracted, I think, by Lorentzian fitting. So you showed the APT at the DNS APT, that if I remember correctly, this is for downfield NOE suppression, right? DNS. Yeah. Okay. And sometimes in the, let's say, in the maps extract by Lorentzian fitted with only APT, we see a decrease signal of APT in the lesion, while theoretically the signal should increase compared to the normal appearing white matter. Why it seems that after you do this DNS correction, the signal is increasing? So you think that there is a strong contamination of downfield NOE, or why do you think that the APT signal is decreasing?
The downfield NOE suppressed approach was suggested by Moritz. I think he's also on the chat, Moritz Zeiss, who came up with this great idea when we looked into the 7T data in patients with glioma. And we tried, or Moritz together with a colleague, Stefan, tried to estimate this fraction of downfield NOE signal. And so they came up with this downfield NOE suppressed approach, where they subtract a fraction that they before determined from the signal that we quantified, and subtracting this underlying downfield NOE signal yielded, as you say, a relative increase of the APT signal. At 7T, this was very helpful. At 3T, this approach has not been applied, or it has been applied, but less promising than at 7T. So this seems to be very different. I don't know if Moritz can speak, if he wants to comment on his experience at 3T with the DNS approach. I'm still there.
Yeah, maybe you can write in the chat. So maybe I can answer another question to both of you, because and then let's see if Moritz can answer in the meanwhile. So my question also for both of you is because you also speak, both of you, in the presentation regarding the CEST role in the distinction from, let's say, tumor progression and the radionecrosis and so on for therapy. Do you have also experience with spectroscopy on this field? So do you think that for molecular imaging, APT and CEST imaging is, let's say, the best solution outside? Or do you think that also spectroscopy can provide additional molecular biomarkers for this, let's say, crucial distinction?
Lucia, you want to go first?
Well, yeah, I think, yes, there's literature on spectroscopy, and it can, on spectroscopy, on radionecrosis and indiscriminated radionecrosis and progression, it can increase the diagnostic accuracy when combined with perfusion. In a clinical setting, we do not often use it. I think that APT increases diagnostic accuracy, the perfusion diagnostic accuracy, and can give a more information on the heterogeneity of the lesion, because we cannot put a lot of spectra inside a lesion. And I think I see in the future more APT in combined with perfusion than spectroscopy, in my opinion.
I think the potential of spectroscopy is very much underestimated in clinical routine, but the very easy explanation for this is that the method still requires experience, is complicated in clinical routine to perform, and also for radiologists to read. It's more complicated than just having images with increased or decreased signal. So that's probably a reason, despite quite well studies published in the literature also showing these associations with high-grade, low-grade tumors, IDH status for different metabolites, like the most well-known choline NAA ratio, which is, like Lucia said, sometimes applied in the clinic, for example, in the question of radionecrosis versus tumor recurrence. But the fact that it's so complicated to perform and to read has made it difficult so far, but maybe we will see some change there in the future also, when we will have these intelligent combined diagnostic approaches where the MRS data can just go into an algorithm, and in the end the radiologist gets a report with suggestions, whatever, and then this information can become very, very interesting again, because it is independent, like I said, also for the APT in the beginning. But as long as we're not there, I agree with Lucia, APT will be more robust and easy to apply, and probably more realistic to have a good perspective in the next years.
Thank you, both of you. We have another question from both of you that is pop out now in the chat. So in treated metastases, is elevation of APT signal suggestive of tumor progression typically seen outside the tumor area of edema rather than inside of the tumor? Do you think you might see APT signal immediately after radiotherapy that is simply related to treatment change? Do you have serial data to illustrate the timing of APT changing versus perfusion changings?
So there's three different questions. So yes, as I said, the APT signal increase outside the tumor. It's something that struck me at first, but I think, and in my little experience, it's something related to progression. The problem of radionecrotic lesion is that they have lots of hemosiderin remnants that affect the signal interpretation on perfusion image, as we said, and that can affect also APT image interpretation. And this is why fluid suppression is needed. So when I see a lesion that it's very necrotic and it has a high signal intensity on fluid suppressed APT weighted, I doubt a little bit on the on fluid suppression also, because we cannot suppress all the hemosiderin contacts. But the thing that brings me, that leads me to the progression diagnosis, it's the higher intensity around the lesion, so outside the hemosiderin remnants. And considering that I didn't well understand that, I think that the second question.
Yeah, I can repeat it if you wish. Do you think you might see APT signal immediately after radiotherapy that is simply related to the treatment change?
Maybe if I understand well, he suggests the idea that we can have some inflammatory reaction that can lead to higher APT signal intensity. I think this is, and if this is the question, so I don't have experience on that, but I think that some very inflammatory reaction can exist, and they can bring to an increase in APT signal intensity, but as an inflammatory reaction. But I don't have experience on that. And yes, I have serial data to illustrate the timing. I'm comparing the timing of APT and of perfusion, and for now I'm seeing that APT changes are earlier than perfusion changes.
Thank you. And Daniel, do you wish to add something?
Just you want to add something, Lucia, or can I?
No.
Yeah, generally for the post treatment setting, again, some expectation management is necessary, because in the studies that we publish and that we see in larger cohorts, we always see these trends. But in the follow-up setting, we have a very, very complicated situation. We have post-surgery, we have post-radiation and chemotherapy, and all these different treatments, of course, have effects on the APT contrast. If it's just edema, this can somehow dilute your signal. Hemorrhage is a problem, can lead to increased signal, and often we don't know the ground truth. That's a problem. So based on very long follow-up, so if you have studies with 1 or 2 years follow-up, of course you can say, okay, we were right, this was progression, this was a stable disease, whatever. But in the very post-treatment situation, it's really, really hard to tell what the ground truth is. And so the very brief answer is yes, all these treatment effects also have effects on the contrast. And I think we need more research also on very precise histological correlations, maybe in animal models. There are some published in the literature, but I think we need more data here to understand the dominant factors, so the ones that really drive the signal.
Thank you, Daniel, and thank you, Lucia. And so I think that we have finished the question. So thank you very much, Avod, for your time, and that was really a great section. And thank you to everyone that was connected to this webinar to have participate with us. And so see you soon. Thank you again for your time, and have a good evening, everyone.
Thank you, Stefano.
Thank you. Thank you, Olea. Thank you, Lucia.